Gauteng, and we have KZN is actually the first branch across provinces. The way we try to spread across more rural areas and to engage communities is through our support groups, which is why I made special mention of them, and training different people from communities to start these small support groups so that we can have links into the communities. And some of our groups have started small, remain small, doing valuable work with their small groups. Some of the groups, for example, our non-support group started as a very small group and has now become their own NGO. So I think the start of the support groups is a way to kind of spread ourselves, even though we don't have physical offices across the country as well. I hope that answers the question.
Thank you very much, Lynn. I think I would summarize your talk to say the most crucial part in South Africa is the cultural and implications on people. As in KZN specifically, when it's spring, we know that people will say it is the start. We will see all those people who have mental health. And I would think people can organize not to distance themselves from people with mental health and psychological. And it is a very common issue where young people, because of depression, commit suicide. But I think, as you thank you very much for your talk, we will even arrange smaller groups to work on that day. So I think you'll keep CGE informed, and we will virtually start the communication and have the work as we have said. Thank you very much, Lynn.
Wonderful. Thank you very much for having me, Commissioner, and I will send through the information via email, and anyone is welcome to contact me still with questions and things. Thank you so much. Sorry to be missing the rest of this valuable webinar, but thank you very much for having me for this short time.
Thank you. I think we'll share notes and other speeches will be shared amongst our speakers. The second speaker is Dr. Leah Mufume. Dr. Leah Mufume was born in Soweto, where she did her basic education. She joined the police straight after school and started studying with the University of South Africa as a part-time student. She worked in South African police services for 30 years, where she occupied various positions, including social work with employee wellness section and human resource manager, supply chain management, and operational commander. What is very interesting in Dr. Mufume's resume is that she holds a Bachelor of Arts in Science from UNISA, a master's degree in public administration from University of Pretoria, and a doctoral degree from the University of Johannesburg. Dr. Mufume has a passion about the wellness and empowerment of women. She is a champion for women issues, not only in South Africa, but in SADC and entire in working with chiefs of police. And I think the wellness, that you've got a background on policing, we're very interested this morning to hear from you. Over to you, Doctor.
Well, good morning, and thank you very much, Commissioner. I want to see whether can you see my screen?
Are you talking about the notes? I see your camera is off now. You're trying to put on the screen.
Okay. Okay, I wanted to share my presentation, but it's fine. I will talk to it. I was hoping that you can see my presentation. All right, let me talk to the presentation. Commissioner, thank you very much for the opportunity. It is indeed a pleasure for me to be here today and to participate in this webinar. As I have indicated, I will be talking about the plight of women with disabilities, but of course I'm focusing on wellness, since that is what is very close to my heart and what I do on a daily basis. Just to mention, we have got a center, a wellness center in Soshanguve, where we do dance workshops, social work services, as well as primary health care. So that this is a topic that's very close to my heart. Now, briefly, I will look at, of course, understanding wellness, and then I will also talk about the different types of wellness, and then issues that women with disabilities are facing relating to wellness, and then we look at what are the possibilities, what is it that can be done. Now, the Global Wellness Institute defines wellness as the active pursuit of activities, choices, and lifestyles that lead to a state of holistic health and happiness. So I have bolded, okay, now you can't see my presentation, but I'm putting focus on the active pursuit of, those activities, choices, and lifestyles, and you will see why. So wellness is associated with intentions as well as choices and actions. So it's actively chasing something that a person desires, taking the responsibility for what a person desires. So there must be options. You cannot make a choice if you do not have options. And then also having the choice to decide how to behave. What are the actions that a person wants to take so that they can experience wellness? So our ability to experience wellness is significantly influenced by the physical, social, and cultural environment in which we find ourselves. And I think, Commissioner, in your opening remarks, you already referred to some of these issues that are facing people with disabilities. Now, wellness must not be confused because most
Dr.
of the
Lynn,
yes, yes, ma'am. Commissioner, can you hear me? Commissioner?
Jabu is assisting to get a back.
Okay. Hello, can you hear me?
Yeah, we can hear you. We lost you when you were just about talking about the appreciation of wellness.
Okay. All right. So I was saying that wellness must not be confused with something like health. A state of being in good health. It must not be confused with a state of just being comfortable, a state of being happy, a state of being joyful or just content. So wellness is actually an active process. So the person must choose what, and they must choose how they want to pursue the life that they want. Let me give you an example. I'm sure that most women, most of us, we want to be healthy, we want to live comfortably, we would like to afford expensive handbags, expensive lifestyles, and, just to be comfortable. And then you can find that in a situation where a person has got, say, a partner that can provide that, can provide for your beautiful handbag, for your car, for, medical aid so you are healthy, but you find that the person still does not experience wellness, so all these things that a person can provide, it's actually also a way of controlling, a way of limiting a person from taking the decisions that they want to take themselves. So a person will experience wellness only when they have got the freedom to define their own happiness and to choose what they want to do to get to that happiness. So a person, if there is a gym in the house, but you might find that, yes, I can use the gym, I can be healthy, but I would prefer to be outside, to be driving myself, to be going to work and all those things, even if I have all the money that I need, but I still will not experience the wellness that we are talking about. Now, the types of wellness, I indicated that we'll also look at the types of wellness. So looking at types of wellness, we have got physical, which is, the healthy body and so on, which I already referred to. But to say that it's not just having that healthy body, it is also about having the ability to make the choices. Mental wellness was referred to now by the previous speaker. The emotional wellness, being in touch with your own thoughts, your own emotions, and having the freedom to express one's feelings. That's part of emotional wellness. The spiritual wellness, we've got social wellness, actively pursuing positive ways to connect with others, but also to contribute to the lives of others is part of social wellness. Then the environmental wellness, where really they must be free of hazards. And that's one thing that most people with disabilities are struggling with on a day-to-day basis. The hazards, the barriers that are out there, be they the natural or the built environment, the physical environment that they have to deal with. Now, looking at women with disabilities, I often say that women with disabilities are our forgotten sisters. As women in general, we face challenges in our country and everywhere else in the world. So there are limitations to women's ability to pursue their happiness, their health, their wellness. Examples were already mentioned, gender-based violence, inequality and discrimination. These are the issues that we are facing as women. Now, add to that being a woman with a disability. So they face even more significant difficulties, both in public as well as in the private spheres. Access to adequate housing, access to training, access to schooling. Instead, you find that people would rather prefer to institutionalize women and children, isolate them from family, isolate them from society, instead of giving them equal opportunities and access to whatever resources that are there. Even as women, I usually find very surprising, where you find that as women, we go out there and we fight against discrimination and we fight for women's rights, but we seem to forget one thing. We forget that women with disabilities are also women. We don't fight for their rights as women. We only fight for, certain women's rights, and forgetting that women with disabilities are women with the same rights that every other woman has. Now, what can be done? I'm saying that we need to end the discrimination and prejudice. The Commissioner has also said,
we're losing you again, Leah. Jace, can you assist us, Jabu? I'm just very sorry, network is just on us. We will just try and reconnect with Dr. Mafome. Okay, I don't think we've lost her for good. Can I be assisted? Days, have we lost Dr. Mafome? Because of that, we have lost Dr. Mafome. I think we will go back to her if we find her back. For time's sake, let's go to Benny Padima. I wish to welcome Mr. Padima. Is the head of policy and legislation and disability rights at the Department of Women, Youth and Persons with Disabilities. He is one of the legal experts at South African Law Reform Commission. He is responsible for the domestication of international protocols such as the United Nations Conventions on the Rights of Persons with Disability, the Convention of Elimination of Forms of Discrimination Against Women, Convention on the Rights of the Child, UN Protocol, and many others. He is a jazz musician, and I think he will speak a little bit about his jazz, and I know that's his passion. His character and ethic values were instilled by many in this country, and including myself as today's moderator. In my life as an educator, I was interacting, and I'm very proud to find one of my own speaking about a very topic which is close to my heart. Over to you, Mr. Benny Padima.
Thank you, Meno Masonto. Dr. Taleng, I must tell you something. Meno Masonto was my matric teacher. She didn't want to tell you that. So I'm actually her product. We want to be able to emphasize a number of matters that relates to women with disabilities. But in principle, matters relate to rights.
Sorry, Benny. I think your speaker has a problem. Sorry, Benny. Your speaker is not very clear. Your speaker, just speak. You are not very audible.
Can you hear me, ma'am?
Over to you, Benny.
Yes. Can you hear me now?
Yes, thank you.
Okay, thank you very much. I was just saying that to Dr. Taleng that Meno Masonto was my teacher in matric, and she took me through the process of schooling at that level. So I'm her product. What we are talking about today is very important. Firstly, we're talking about the rights of women with disabilities. What do they entail in principle? Except the question of wellness and health and other reproductive rights, women with disabilities have got exclusive rights. If you look at Article 6 and Article 7 of the Convention on the Rights of Persons with Disabilities, it talks exactly about the issues of women, but it includes and not limited to girls with disabilities. The reason is that they have to get special treatment, but they must be recognized as part of society that plays an important role as any other woman in this country. The Department of Women, Youth and Persons with Disabilities has made a special allocation for women with disabilities programs. The reason being that we want women with disabilities to participate in the following projects. The first one is called One Woman, 1 Acre, or 1 Woman, 1 Hectare of farming. We want women with disabilities to start farming. We have an allocation of 700,000 hectares, and we want 7% of that to be allocated to women with disabilities. Secondly, we've got the bakery projects. The bakery projects are in respect of women with disabilities producing bread where they live and selling to the local spaza shops and any other business that is included or inclusive within the processes of empowerment. The third project relates particularly to women with disabilities participating in the post bank and owning shares as part of the post bank. The total amount is 40% of that allocation, but 7% of the allocation will then go to women with disabilities. The emphasis hereby is placed on the fact that women with disabilities are able to be independent, and they are able to be assisted and also be assessed as any other person. I therefore would want to make an appeal that we should not see them as a risk, but rather as an asset to the nation, which can participate in the economy of the country and also provide and pay tax as any other citizen, while they are also providing for their families. I therefore do not want to emphasize the struggles that they go through on a daily basis, but just to mention a few. Women with disabilities are subjected to triple discrimination, and this is because of the nature of their disability and the severity of their disability. The second point is that women with disabilities undergo discriminatory hate speech. The reason is that, Dr. Tlaleng, for instance, when they get to a clinic, the first thing that they ask when they are pregnant, they ask them, how did you make the baby? It's a strange question because people believe that women with disabilities are asexual. It's not true. They are like anybody else. They live any other lifestyle like anybody, as long as you give them space to be who they are. The stronger they remain, the better they fare in the economy of the country, in the health services of the country, in caring for children, for instance. And I can tell you, Chair, also, that we would like to encourage women with disabilities to start talking to us about early childhood development, because it's important for them to participate in the expanded public works program that is now in place as I speak. And therefore, we would like the 7% target on equity to still remain in that EPWP. We have made a decision with regard to that, and I have spoken to the Department of Social Development in that regard. Chair, in conclusion, I would like to say that the department has had consultations with women with disabilities, and in the discussions with them, they have indicated that their plight is not a plight of discrimination only, but it's a plight of isolation, and it's a plight that is almost close to racism. We therefore want to make an appeal that we look at 3 legal instruments. Dr. Tlaleng, we are looking at 3 legal instruments, which is the Domestic Violence Act, the Criminal Matters Act, and the Judicial Matters Act. In those 3 acts, we would like women with disabilities to be included, and their matters must be considered from a judicial point of view. Those acts are now available on the website of the Department of Justice, and I would like to ask that women who are participating today in this webinar must make input into those particular acts. Those acts are very, very important, but also what we are trying to do, Dr. Tlaleng, is to strengthen the issue of bail, so that if a woman with a disability experiences problems with the husband must get out of the house, and they must not be granted any bail. So we are getting to that point. So we have put that also as a recommendation. Apart from that, there's also the Sexual Offences and Related Matters Act, which is looking at sexual offences, particularly at women with mental disabilities. In that act, we are very clear that if anybody rapes a woman with mental health issues or mental disabilities, they should get a maximum imprisonment of 15 years. That is a standing item, Dr. T, in our courts as I speak right now. But we are increasing the number of women with disabilities in that case because we are only looking at women with mental health issues or with mental disabilities. We are increasing that to all women with disabilities. So it's a maximum imprisonment of 15 years with no fine. And that option is not open. Chair, in conclusion, I would like to thank you for giving us the opportunity to speak to women with disabilities. We've done it as a team in the department with the Deputy Minister of Women, Youth and Persons with Disabilities, and she is appreciative of the fact that we have done this work. We know that you are a very strict person, especially when it comes to disability, and you are very passionate about it. And Dr. T, I can assure you that when you go back to the UN, please let Mepunzile know that we've got a very strong lobby group for women with disabilities in South Africa. I thank you.
Thank you very much, Benny. It is unfortunate that you chairing this session and you thought you were writing your exams, but as a person with disability, to every hour you will get 15 minutes more. So I open this time to say well done, and I will like to open for questions, but I would like to acknowledge the acts that are right now being, we spoke about that in our plenary in the 2 days, and we will make inputs as individuals and as CGE. And I would like to acknowledge that 1 hectare, 1 woman was championed by Dr. Mgodli, and we are very happy that it was championed by CGE, and I would like to take it upon myself to say we will encourage the women to go and get that 1 hectare and be farmers. I know that one of the commissioners is very interested in women in economical upliftment, that you are looking forward to the bakeries, that bread is one essential thing to each and every family, be it in town, be it in the rural areas. Every family wakes up to having bread. And the post bank, I think I would encourage all of us to go and get those shares. It is given 40% to women, but I would encourage women with disabilities to say, let's grab the 7%. And then I was very important and excited that you're speaking of the early childhood program. As a former teacher, I will encourage other young women to go and train in the EWP administrators in early childhood, because if children see another person with a disability, it is an encouragement that you too can do it. Let me not be selfish and boast about my student. Can I open to 4 or 5 questions before I get back to maybe finding? Augustine has a question, and can those questions be read out to us by one of the commissioners, as Benny Padima is blind, and I don't think the assistant is there to braille them quickly to him. Commissioner Muliko, can you assist us with a few questions that have come up?
Thank you, Com. The inputs on the on the chat is that, can we please also add Victim Empowerment Services Bill, which was mentioned by our speaker, and that we also mobilize in relation to the psychosocial and mental health needs of women with disability, that they be taken into consideration there. I think that's a comment. The second question from Commissioner Matebula is there any disability index in place to track the impact of service delivery related inputs on outcomes for women with disability? I'll repeat that. Is there any disability index in place to track the impact of service delivery related inputs on outcomes for women with disability? I'll hand it back to you, Chairperson.
Are those the only two? I had indicated 3 or 4.
These are the ones in the chat box.
Thank you very much. Over to you, Tate Padima.
She keeps on moving in and out, and she's supposed to be sitting here and pressing the buttons.
Yes.
On the question around further inclusion of other acts, yes, we are considering that. Victim Empowerment Act will be included in the process, but also there will be a process of ensuring that that has an exclusion section. So we'll make regulations on some of these acts so that we don't miss the point. On the specific programs related to women with disabilities across government, our approach is that we consult all the stakeholders. Women with disabilities are actually organized. They've got their own organizations. Sometimes it requires that we consult women who are deaf. Sometimes it requires that we consult women with mental illnesses and so on. But what we try to do is to make sure that all those women are actually intact in terms of getting the services. So it's a service basket, as I've explained. That basket might not be enough, but it's important that women with disabilities also participate in the sending projects, and they also become a part of what you are recommending. I have taken your recommendation, and also the question. I've taken that into consideration. I will have a discussion with the Deputy Minister, and we will then also revert back to you. If you can get the email address, and then we can come back to her on the matter.
Thank you very much, Tate Padima. Can I inquire from Deputy Chair if May Leah is back? Before I...
Yes, she was back. Commissioner Masbugo, she was back. Yes, she's back. Please ask her to keep her video on so we can see. She's back. There she is.
I can't see it from my screen, but welcome back, May. That is the issue of RI4. When at the commission, they always say, it tells our age. Anyway, welcome back, and then let's blame it to the weather, and Vodacom is just very jealous of this wonderful webinar. Thank you.
Correct.
Over to you, Leah.
All right, no, thank you. I'm sorry about that. So let me continue from, I think I have explained the difference between wellness and just the state of being happy and so on, the importance of the person being involved in the process of making sure that, they experience a good life, they experience that wellness. So I just want to continue and talk to what is it that can be done, what should be done. I have mentioned, I'm not sure whether that part you heard, but I think that's where I got cut when I was talking about the fact that we do have policies, but these policies do not necessarily adjust, sometimes become shelf documents, sometimes issues of compliance, so that at least we can tick the box. And since most of us have experienced discrimination, we should use that experience and that understanding to, to understand that even women or people with disabilities experience the same kind of discrimination, and we know the pain that is associated with that, and above the pain, it is actually just wrong. So we need to change the belief that discrimination is bad only if we are the ones that are on the receiving end. If people are discriminating against me because I'm a woman or because I'm black and so on, then it is bad. But when I'm doing it against my other sisters, then we feel like, no, it is fine, it can be done. So we need to move from there. And another thing is that as women, we are very good in creating networks. We are very good in connecting with other women, and we're even good to use those networks to influence society. For example, we have got Stockfeld, we have got social clubs, we save money together, we buy each other secret purse. Now Christmas is coming, we'll be sharing secret purse in those networks. But we seldom involve women with disabilities in our networks, to an extent that even when people want to go for the end of year function as that network or as that social club, we will choose places that are not conducive for women with disabilities, and we use that as an excuse as to why we're not involving them. So maybe at this stage, I can also share that at Zonaga, as I indicated, that we run a wellness center in social movement. We have got group sessions that we run on various topics with women. And we also allow women with disabilities, to form part of our group sessions. We have got the dance. I mentioned that we also give dance workshops for youth and children. It's not only limited to, because as I've been explaining, that with wellness, the reason why people with disabilities sometimes cannot achieve what the length and the extent of what they can achieve is because we as society, we limit them. If we can start and saying, okay, for the ballet class, because one of the classes is the ballet class for children, if we can say, for the ballet class, if you have got, say, one arm, you cannot be part of the ballet class. But why? Because then it means that we will never know, even if there's a child that could have been the best ballerina, that we are going to say, no, she can't be part of this, or he can't be part of this, just because, of the disability. Another important thing, looking at what should be done, is the way in which we nurture and socialize our children. The reason why we have got these physical barriers that make it difficult for people with disabilities to pursue their awareness is because of the way we nurture and socialize children with disabilities. The shame, concealing them. If I've got two children, one has got a disability and one is the so-called abled, then we end up concealing the other one. The lack of knowledge, it leads to ignorance. I always look at people like me who are scared of snakes. Most people are scared of snakes. But the reason we are scared of snakes is because we are ignorant about them. We do not know a difference between a dangerous snake or just an innocent snake. I believe there are snakes that you can just hold with your hand and throw it that side. But some of us are scared just because of that ignorance. And I think this is almost the same as when if I have a child with a disability, instead of finding out what can this child achieve, what are the child's strengths? If the child might be having just one element, maybe she's blind, but she's intelligent, she's not stupid, there's a lot that she can achieve. But instead, we socialize them and nurture the children in such a way that we restrict their ability to experience that wellness. changing attitudes, the cultural barriers that we have, as well as the physical barriers. Physical barriers don't make themselves. Parking bays, the toilets, as I talk about our dance studio in Social Movement, if we build it in such a way that it only accommodates people who can walk up the stairs and who can do this and that, we are automatically excluding, people with disabilities, which I think is out of our own ignorance. Now, we have to recognize the fact that we have got challenges. We who think that we don't have disabilities, we actually have challenges. Policies, I've already said that they do not bring change, but it's people who will bring change. We shouldn't provide solutions such as, we say we provide an institution or a facility for people with disabilities, but people with disabilities must be the ones who are deciding what are the solutions that they want, how they want to be involved. Stop creating all these barriers that we are creating. Providing opportunities and the ability to choose, to make, having those options so that they can make their own choices. Chairperson, I want to conclude with some examples, of people who really have gone in pursuit of their own wellness, and there are many, many of them. But I'm just gonna, mention a few, three that I have identified for this purpose. In South Africa, we are blessed to have a blind man. We call him a blind man with vision. His name is Hein Wagner. Although this man was born blind from childhood, but he has achieved so much more than even some of us who can see. So a lot of people can see, but they do not have vision. And then we have got this man who has completed a number of marathons, including the 2 oceans, the New York Marathon. He has climbed many mountains in the Western Cape. But the worst one that he did, which was a real wow factor for me, was the fact that he holds the world record as a blind person to drive a car at a very high speed of 322. Well, I'm a former traffic officer, so driving a vehicle at 322 is not done, not on the road, but we know that he was driving it under specific conditions. And that just shows. Then there is another young man who is Nick Vujicic. Nick was born in Australia. He was born without limbs, and I'm sure there are many other children who were born without limbs. Imagine as a parent, when you have a child, this child comes out, he does not have legs, he does not have hands. But Nick, as a child, he was bullied and he was ridiculed and discriminated against. When he was a teenager, Nick tried to commit suicide. And these are the things, he wasn't committing suicide because he was not happy about himself, but it's because of the way society and other children were talking to him and behaving towards him, ridiculing him and so on. And he tried to commit suicide. But he has managed to pursue his wellness, that today he's a world-famous motivational speaker, and many others. The last one I want to refer to is our very own KG, Khutato Monchane. This young woman was born in Seshego, in Limpopo, and I'm sure she also, like Nick, went through issues in her life. And then at the age of 12, because she was born with some defects at birth, her foot was amputated. But she became the #1 wheelchair women's tennis player in South Africa and #9 in the world. And there are many more. What it shows is that why I refer to these 3 people and others is that the way we socialize them and give them an opportunity and not conclude that a person can't do certain things is what is important, to make sure that they achieve wellness. Let me close, Chair, by referring to the phrase, nothing about us without us. We know that phrase, but most of the time we want to decide for people with disabilities. We want to decide that, no, they can't do this job. When I grew up in the police, I used to see people with disabilities only working switchboard, as if they were just, and at that stage, as a young a policewoman, I actually thought they can't do anything except switchboard. Until later on, you realize that no, it is the workplace that was channeling them to only do the switchboard. Meanwhile, there's a lot that they can do. People with disabilities, they know what is best for them. We should just give them the space and the freedom to define their own wellness and actively pursue what they want to achieve. As society, we must stop placing emotional, social, physical, and cultural barriers that make it difficult for people to experience a good quality of life and to become the best that they can. You know what? After all, disability is only an incident away for all of us. Anyone can become disabled. I can stand up from this chair, and the next time you look at me, I might be disabled. And I thank you, Chair.
Thank you very much, Doctor. I think you had to go back and get power, and it has made our day. Specifically, I would like to thank you when you spoke about and gave us to say interactions and actions and our opinions are our wellness. And it is very confusing when you look at healthy, but even those people who have expensive cars, expensive handbags, who live in triple-story buildings, but because they are not happy, the wellness comes in. And thank you for telling us the emotional, the spiritual, the social, and environmental, physical types of wellness. And when you spoke about nurturing and the nurturing and societal issues, those we see daily as persons with disabilities, because society will paralyze us to say, okay, stand aside. Even at school, when you are supposed to go and play with us, no, sit down. You can't go and play because the sun is, you are very sensitive to the sun. And today, I think we have mixed issues to say it's not for us to choose only and take, as Benny has spoken, to say we are all going to be farmers, we are all going to be bakers, we are all going to look after the shares. But you open it up to say the sky is the limit. Mark, you are coming from Pretoria, I don't favor sundowns, but I'm saying to people with disabilities, behind the skies, there's life. So that says to me, thank you very much. I will give this time, because we still have time, we'll give it over to the Deputy Chair to assist us with the chat box, and then we can hear you answering some of our questions that we have got. Deputy Chair, over to you.
The first question I'll just read is from Stolile Ngobo saying, how are Indigenous knowledge systems integrated into the wellness and mental well-being of people? Do you have an example that you can share? I'll repeat that. Are the Indigenous knowledge systems integrated into our wellness and mental well-being? Is there an example that you can share? Leo just commented that more needs to be done regarding disability and mental health. The other comment I also want to put before our panel member is the second question: is there a disability index that is in place that can track the impact of service delivery related inputs on outcomes for women with disability? From Chairperson Matebo, is there a disability index that is in place that can track the impact of service delivery related inputs on outcomes? Those are the two questions. There's a new message that's just come in. It's just about the recording. Those are the questions to the panel member. Thank you.
Deputy Chair, over to you, Doctor.
All right. No, thank you. I see this question: how are Indigenous knowledge systems integrated into the wellness and mental well-being of people? And if there is any example. Well, maybe from my side, I must say that I might not understand the definition of Indigenous knowledge systems, what the the speaker would be referring to. But from the way I understand it, when we talk about wellness, the most important thing to remember is that whatever systems that we have in place, they cannot be put and decided for the person that is supposed to benefit from them. That is the most important thing. So whatever systems that we have in place, a person can never achieve wellness if they are not part, they do not decide and say, this is how we want to make use of whatever resources, whatever opportunities that are there. Limiting them. So the focus that we have on when we focus on wellness, we are saying that no one is stupid, no one is cannot do certain things. If a person can't do something, we have to accommodate them within the level that they are able to perform. So that we do not put people aside, like the chair was saying, to say, no, you sit aside, you can't do this just because maybe we want you to jump, say, 5 meters. But a person's ability is to jump 4 meters, and therefore we will make provision for the person to jump 4 meters. Let me give an example. I spoke about the dances, the ballet dances. You know that most of, even if I put aside children with disabilities, most of our black children, because of the build, the way their bodies are built, they would be disqualified to do a dance such as ballet, because even when you look on the TV or where the ballet originated from, it is focusing on those children that are very, very thin and their legs are facing outside and so on. And as a result of that, you would find, and that is why at Zonaka, what we are doing is to say, no, we will make sure that these children, within their abilities, with their big African bodies, they can still enjoy ballet if it is a type of dance, a type of sport that they want to be engaged in. So for us, wellness is more about allowing people to be who they can be.
Thank you, Doctor. The index question from the chairperson.
I will have to maybe do some research a little bit on that, Chair. I do not know whether there is the index, disability index. No, I'm not sure of that one. I don't know if the other panelists, maybe they have got a response to that.
There's a hand that is raised. Deputy Chair, can you assist?
Chair, maybe perhaps I can
Yes,
assist
Dr.
Penny
Padilla.
speaking. Yes, Chair.
You can speak,
Penny
Dr.
speaking.
Padilla.
Yes, I can assist. Yes, Chair. Chair, there is a Disability Inequality Index currently, which is in place. We are piloting it across the country, and it includes women with disabilities. So we are looking at statistical variations, we're looking at monitoring and evaluation tool, and we are looking at equity targets of 7%. We have already informed the Menomas about the inequality index, but the recommendation from women with disabilities is that the index must be taken to the United Nations organization. So we'll have to take it through UN Women in order to be able to get all the correct answers. But the index is there, and if it's needed, I will also send it to Mayor Matebula through the office of the Deputy Minister as required. But the index is definitely there. It's actually covering the analysis of household surveys, opinions, as well as participation of women with disabilities within the process of the United Nations Convention on the Rights of Persons with Disabilities. Thank you very much.
This question, Doctor, comes from me to ask to say, what is it that you're doing to advocate and educate the wellness in, especially for women who are having high positions? Because there, when the higher you go, the colder it becomes. And we see that a lot of women are not coming out. So what would you recommend, or what would you assist us in this webinar to say, how does the person come out? Because immediately you declare to your supervisor, then you are in trouble. So most of the time, women with depression do not want to declare because it's still a stigma. So in the wellness, and some of the medical aids do not pay for, as far as I know. There are limitations toward that. Thank you.
Yes, no, you are correct, ma'am. As a matter of fact, even insurances, once a person has declared that they were having some mental wellness issues, then you find that they do not pay for certain things, or they exclude you from having a cover on something. So what we now, with regards to your question, really what we do, we have got conversations with women, which we call spill the tea. So we have got sometimes they actually during the lockdown period, we made them weekly conversations where we would get together with women on a platform like this, but we use mostly Zoom because it's easier to use. So we have this platform where we get together with women, and we're discussing topics such as those, because that was also a time when a lot of women were experiencing wellness issues, mental wellness issues, the domestic violence, the difficulties that people were experiencing at home and are continuing to experience, really. So that's what we do. We have got those conversations. They are on Zoom at the moment because of the lockdown. But before we had the lockdown, and also now that we've got a little bit of space to can have small meetings, we will continue with our conversations with women. But we don't just talk, because then it becomes just a talk show. We also involve men, because most of the time you find that the women are not really causing their own mental issues. They are perpetrated by the men. So we also have group work that we have with men, and then we refer for services that are, if people need to get to see a doctor, or they need to see a psychologist and other people, as well as other structures within the community, the churches and other structures that are there in the community. So we refer them to those structures. So our groups are made in such a way that we would say it's not just only people who are experiencing these issues, but we would also have a group. Out of the discussions, maybe you find that discussions are that people are not able to report in their workplace. Then we would have a group then of senior people in the workplace from different angles. And as you have heard, I'm also involved within the region. So we also sometimes have managers from the region, so that they can share and hopefully, help each other to change the way they see things, to understand issues of wellness and the importance of having happy employees, because it's only when you have happy employees that you can have happy customers, and happy customers will hopefully make your company to achieve more.
Before I let you go, I will inquire from Deputy Chair if there are maybe other comments or questions. Over to you, Deputy Chair.
Thank you. It's a comment on the bill. Nomfundo from CSVR just says she's appealing to comments to be made to the Victim Empowerment Services Bill. It's in the chat box, the email address to the Department of Social Development, to highlight the needs of women with disability within that bill, if some of the recommendations can be taken to the bill. Thank you. That's the only comment.
I think, Doctor, we are very pleased to have this communication with you. You are very near to us. We are in Pretoria. We also have an office in Pretoria, and I think as a Gender Commission, we are going to be in constant interactions with you, because as it is we are a Gender Commission, and that you're starting the girl child from the socialization and cultural beliefs and backgrounds. I think it's very important, because as we go up, a lot of young children, I was sharing with Dr. Tlaleng that many young children are depressed, and very, very much because of lockdown. Thank you very much. I think you are going to be with us still, and then you can sit in. Now it's over to home. I would like to introduce Dr. Tlaleng Mofokeng, UN Special Rapporteur on the Rights to Health, Commissioner at the Commission for Gender Equality, medical doctor and sexual and reproductive health and rights, expert in South Africa. Dr. Mofokeng has expertise in clinical services, comprehensive sexuality education, training and facilitation, and content production, amongst others. She has a global advocacy experience at the UN for Human Rights Council, in the UN Commission for Population Development, and the United States Senate. She is author of Dr. T, A Guide to Sexual and Health and Pleasure. She facilitates advocacy in practicing training for global doctors' choice and global health strategies. She holds a Bachelor of Surgery and Bachelor of Medicine from the Nelson Mandela School of Medicine in the University of KwaZulu-Natal, Durban. Dr. Tlaleng, you're welcome to this webinar. Over to you. Thank you.
Thank you so much, Commissioner Mazibuko, and thank you to all the panelists and everyone who has attended. And I see in our presence we also have our chairperson, Mr. Mara Matebula of the Commission for Gender Equality. The Commission for Gender Equality is an independent statutory body established in terms of Chapter 9 of the Constitution of South Africa. And the powers and functions of the Commission are outlined in our Act. And more importantly, it's important for me to draw and your attention to the fact that our mandate is to promote respect for gender equality and the protection, development, and attainment of gender equality. And this webinar this morning is part of that work to develop and attain gender equality, with a specific focus on mental health and the intersection with disability. Physical, mental, developmental, or cognitive disabilities exist. These can be either congenital or acquired disabilities. And disability is a recognized grounds for vulnerability and discrimination in international human rights law and in our Constitution. And race, gender, class, migration, health status, and geographical placement can lead to rights abuses and further marginalization of those with disability. The right of everyone to the enjoyment of the highest attainable standard of physical and mental health is related to many other multiple human rights. And as the Commission for Gender Equality, we draw on international human rights laws and standards, the Universal Declaration of Human Rights, the CEDAW, the AU, Maputo Protocol, Beijing Plus 25, our own constitution in South Africa. It's a human rights-based framework, and specifically legislations express the right to health as well as reproductive health. And we also have the Mental Health Act in South Africa, which governs what should happen with those people with specific mental health needs. I just want to focus our attention on a couple of these rights that are important to the realization of health. It's the right to dignity, the right to information, freedom and security of the person, the right to equality and non-discrimination, and the right to bodily autonomy. And I want to draw us to a very recent experience as South Africa that we've had, the Life Esidimeni case that we all know very well. And if you can think of that case, you can see about how some of these rights I have just referred to were abused in those instances, and in some areas, clear violations of human rights. Some of the determinants of health include social structures in society, strength of community systems, speed of scientific advancement, politics and prioritization, as well as the legal environment. I'm going to focus slightly on power asymmetries when it comes to patients and end users of mental health. Now, the protection and promotion of human rights and mental health is reliant upon a redistribution of power in both the clinical setting, research settings, as well in public policy. And decision-making power in mental health is still concentrated in the hands of biomedical gatekeepers, people such as doctors, nurses, health systems, and of course the law. And in some instances, this gatekeeping is backed by pharmaceutical industries. These power dynamics often undermine the principles of holistic care and governance for mental health, as well as innovation and interdisciplinary research. We already heard earlier on someone asking about indigenous health systems, and this is why it's important that as we think and reimagine a world where mental health rights are not abused, especially for people with disabilities, we have to think about interdisciplinary approach that does not neglect the importance of traditional health African indigenous practitioners. Now, at the clinical level, this is whether it's primary health or tertiary health care or community health, these power imbalances are reinforced, and the paternalism and even patriarchy approaches that medicine adopts often leads to domination of the relationship between psychiatric professionals, the nurses, the doctors, and other allied health practitioners, and the users of mental health services. So by the time someone presents to a health service, there's already an asymmetry and a disempowerment of the user, undermining their rights to make decisions about their health, and creating an environment human rights violations and abuses can occur, and we know in this country they occur, and often it's the law that governs sometimes the psychiatric profession that can in fact be misused, and the power asymmetries then thrive because of sometimes the legal provisions and the policies. What's important, especially when it comes to issues of healthcare and who can consent to what services, we know that in practice, many children who are mentally or cognitively delayed in terms of development, or even older persons who may have some psychiatric illnesses or disability, are often forced and coerced into being sterilized, either by long-acting and permanent methods such as hysterectomies, but often it's the subtle contraception that people are put on without their consent or through coercion. And this is something that's documented throughout the world, and it is a problem that we continue to experience in South Africa. A few years ago in the Northwest Province, in fact, there was a case that was covered that was talking about how children in certain schools were put on long-acting contraceptives who were institutionalized, and some were not even patients with disabilities, and they were said to be given vitamins. Meanwhile, those injections were actually contraception. And so we need to think about how in the clinical practice already the power dynamics and the asymmetries make for a state where abuses can happen and human rights violations have been documented. There is also a framework that is very important that the UN is currently working on. I know, Benny, you made a few references to the UN and those processes, and they are very important. And the Convention on the Rights of Persons with Disabilities is an important international human rights law, or at least standards and framework that we can use to either analyze our own policies or then come up with different legislation and suggestions for amendment, which is also part of the work that the Commission does. With COVID-19 specifically, just to focus on this, it has been a stressful time for all of us. The fear and anxiety about this new disease and the overwhelming, strong emotions, both in adults and children, has caused a public health crisis. And as much as the health information has been around social distancing, wearing of masks, and washing of hands, people have felt isolated and lonely. And you can imagine then, if you are someone who's already lonely and isolated because of a disability, what the lockdown regulations actually meant in terms of your mental health when you are already living in a distressed state. The health and wellness of healthcare professionals is also important, because these are the people who are essential to providing services. And if the health and wellness of healthcare professionals is also not taken seriously, it means the quality of service they offer to the end user will also not be of quality. So we have to talk about occupational health risks. We have to talk about workplace programs for employees that can make sure that the employees themselves understand, can see, and are able to recognize their own mental health needs, their own exhaustion, so that they don't project, or in some instances abuse, the very people who they are supposed to be taking care of. Challenges that are constantly emerging and reported around access to mental health services for people with disabilities are simply around availability. We do not have enough available public health clinics and resources for people with disability. Accessibility is another big issue. A lot of clinics are still restricted in terms of mobility. They don't have ramps for wheelchairs. But remember, disability is more than just physical. You need some people to be able to access Braille and access health information using visibility or hearing enhancements, or assisted graphic descriptions, or screen readers for digital content. Many clinics have televisions and videos and other digital media, but even those platforms still lack accessible information for people with disabilities. So you can imagine during COVID, when the masks are being worn across the face, when people who depend on lip reading can no longer lip read to improve or enhance their ability to communicate, what that then means for the groups of people who have disabilities. And the right to information is a human right, and it's a right that's protected by our Constitution. So these are not added extras or a burden that we are asking for in terms of, for people with disabilities. These are about protecting and promoting access to information, which are human rights. The other issues, of course, in terms of a lack of public transportation around the curfews, they've since been relaxed somewhat during this level 1, but there is still issue about accessibility and nighttime accessibility. We know a lot of gender-based violence and sexuality-based violence in this country happens at night. Sometimes it is by strangers, often it's people you live with. So how does it mean if you are unable to communicate, to ask for assistance using a cell phone or any other method when you are confined to the home with your abuser? Even when you get to a health clinic, the J88 forms, which many of us use in medical forensics, are only in English. There are no Braille forms available. There's no interpretation and translation. So not only are people with disabilities at a higher risk of abuse, because people know generally they cannot access the police, they cannot access the Department of Social Development, they cannot access clinics and hospitals, but even those who do access, the quality of care that they receive is very, very much subpar. And of course, the international human rights law guarantees the right to non-discrimination in the access to and delivery of mental health care services, and of course the underlying determinants of health. And the right to mental health is also dependent on equality, which is why it's important for the Commission for Gender Equality to be hosting this webinar, because it is really falls within our mandate to ensure that non-discrimination in the enjoyment of all other human rights are considered and of course are placed in the forefront as already existing grounds for discrimination. Now, there are of course multiple and intersectional forms of discrimination that continue to impede the ability of individuals, women, the racial minorities. We know the Afrophobia that's currently happening in this country, particularly related to civic services, and that this discrimination and inequality are both a cause and the consequences of poor mental health, and the long-term implications around morbidity, mortality, and generally societal well-being demand of all of us to actually end discrimination based on class, gender, race, physical ability, migration, documented refugees, and those people who are fellow Africans in this country. And of course, we have to talk about stigma in the community, in the family, in schools, and in the workplace. And the stigma often leads to social disconnections between people. It breaks down the little support that's there, and the environment don't become inclusive because of stigma. And so it's very important that even in the laws that we are thinking about reviewing or informing or advising on, that we look how the law in itself and the policies in themselves, and how in practice and how those policies inform clinical practice can in themselves constitute barriers for those requiring emotional and social support. Now, in conclusion, Commissioner Mazibuko, I just want to say that it is important to also talk about discrimination when it's relating to depriving people with disabilities other rights, right? Because there's this assumption that because someone is disabled, they lack capacity to take certain decisions. And it's important to realize that people with disabilities have legal capacities, they have rights to privacy and other civil rights and other human rights. And so the role of psychiatry and other mental health professionals is particularly important to make sure that we do not violate or abuse people's rights by using their disability to then not allow them to make those decisions even where they have capacity. And in South Africa, we've got the Children's Act, we've got the Mental Health Act that provides an environment where even if doctors and nurses think a patient is unable to make decisions, there should be some protection in the Act and in how we treat people with disability and, of course, mental health issues. And it's very important that, we have to think about how we discipline children. We have to think about the issue of violence in South Africa. We have to think about how even in childhood, people are experiencing trauma that remains untreated, and they become adults who have emotional, psychological traumas that are either buried or that then impact how they behave in society, and how often our approach to mental health actually means we live in a country with such high incidences of violence, and we often don't see the link between a lack of mental health services for the community in general, but specifically also then for people who are marginalized because of disability. We have to integrate mental health and psychosocial solutions into all responses. We have to ensure a seamless referral between Western medicine practitioners as well as traditional medicine practitioners. Many people, and this is not even a rural area issue, many people, and even in the entire continent, still depend on traditional medicine practitioners first. And when those have failed, then people are then more inclined or ready to come into the Western health medicine. So we can't discuss the issues of mental health and well-being and not talk about a seamless referral and a working together in terms of research, biomedical development, and protocols that incorporate indigenous health systems. And it's important that information is gender sensitive, even when you are doing assessments or collecting data, because this will help us identify the needs and the gaps, but also map existing resources. I think it's very important to be able to refer people, even if, for example, as a Commission for Gender Equality, we are not a program or service provider, but we should be able to refer to existing resources and make sure that we are systemic in how we identify and make sure that the people who are disabled are served and that there are provisions to promote and protect their human rights. And of course, we have to talk about other protections of vulnerable groups, because disabled people are also LGBTIQA+ individuals in that category. They may be older, they may be people who are pregnant, they may be experiencing gender-based violence themselves, so that we don't remove the issue of disability from the bigger discussions around the country, but actually be intentional about including those people who are already experiencing stigma or discrimination because they are disabled, but not to disintegrate disability issues from other issues. So we actually need to mainstream the issues of disability as opposed to removing them and further isolating them. And I just wanted to say, with what Benny was saying in terms of the existing work and that he wants to share at the UN and with the different ministries, I think it's important that the Commission for Gender Equality, through our public education and information, as well as our research departments, we are very well placed to inform advocacy nationally, regionally, and internationally. And we have status at the African Union. So we need to utilize that status that we have as a national human rights institution for accountability and establishing regional best practice for clinical service, law reforms, as well as community involvement. Thank you very much, Commissioner.
Thank you very much, Dr. Tlaleng. I think before I open to questions through you, Deputy Chair, I think what is very important to this presentation that you have made is to look at the integration between traditional medicine and the Western medicine, where we find that people will prefer, it's true, they go first, and it's not an issue for the people who are in the rural areas. Even in the urban areas, people do that. But you have given us a wealth of information that we think, which I think is very important. But let me first ask the Deputy Chair to get our questions so that we summarize and get where to now, because this is not a talk shop, and you have interwoven it very good with wellness, with the disability which Bennett spoke about, with the issue that Lorna spoke about, so that where do we go from here? I can very easily say it was difficult when we prepared this webinar to say, what is it that we have as CGE that we can stand upon? But after this, I think colleagues are now aware that there is a need, an immediate need, and to collate it together with the pandemic. And the pandemic has opened very wide avenues that needs our immediate attention. Over to you, Deputy Chair.
Thank you, Commissioner. Thank you, Facilitator. Questions that have come from this portion. Comments, well said, Dr. T. Western and traditional medicine coexist. We need a multidisciplinary approach. The comment is, one, more primary health care for mental health and disability care is needed in communities. Traditional healers and caregivers, as well as activists, could be trained to assist in mental health and disability. The request has come through that all the members, the panelists, share their presentations to joan@cge.org. The second comment is from Leo about integrated care and collaborative care, which are models, increasing emotional intelligence as well as improving psychological flexibility. They cite that mental illness is the cause in 4 out of 10 disability claims, and 7 out of 10 youth in state and local justice systems have a mental illness. I think that's a comment. The holistic approach is confirmed, and then Commissioner Ndulito Batla says thank you to the powerful platform and expert opinions by the panelists, which are on point. And moving forward, we need to vehemently implement the recommendations and best practices learned. Thank you, Commissioner Masbuko. Those are the comments.
Thank you very much, Deputy Chair. I think the quality of good health and poor mental health to this country, the equality that we find as people with disabilities, I would strongly speak of the issue of sterilizing mental health survivors, where we find that if by the time you always yearn to have a baby as a young or an older woman, you don't know that you were sterilized because of the fear that the family and the culture has done us very, very badly. I think what we have found this morning is that the correlation between the Department of Women, Youth and People with Disabilities and CGE and a Lonas organization in KZN and Melia in Pretoria. We need to come along. I definitely say we will have and expect that we will work on this. It's not going to be a talk shop because we don't know how far we're going to have this pandemic. And I would at this juncture ask the chairperson of the commission to make few comments, and then at the end the deputy chair will make a vote of thanks. Thank you very much.
Hold on, at least it's about to finish now, Joe. Okay.
Over to you, Commissioner Chairperson Matebula.
Thank you
very much, Commissioner Mazibuko, and I just want to thank the panelists for the inputs provided regarding mental health and its impact. I just want to say that based on the inputs, there are laws, there are quite a lot of legislations that we need to look at, and there are bills that are currently in place that we need to input into so that we integrate issues of mental health, disability into those so that they can be translated into not only planning but programming as well as budgeting. I must say that perhaps if you look at the recent spate of COVID-19 lockdown, I think it has actually brought quite a lot of awareness in terms of looking at various groups, including women, elderly women who are left lonely, during this COVID lockdown period. And I must say that perhaps the lockdown period was an opportunity, that was actually eye-opening for the whole nation, for the whole SADC, but also worldwide, in terms of how we need to now focus on issues of mental health for people that have been or have remained behind closed doors for a long time and have experienced loneliness during lockdown. So I find that also included in all of this were the issues of hunger, the issues of consequent poverty that we have actually seen, and you will find that in all of that, those things have actually contributed to quite a number of issues that impact on mental health, which has a long-lasting impact in terms of lockdown and beyond. So I think the country, the organizations, both civil society organizations as well as government, need to look at the long-term impact of mental health, not only during lockdown but beyond lockdown, so that we can actually plan and do programming effectively and efficiently as we move forward in addressing the substantial increased anxieties and depressions that each and every person has actually experienced during the lockdown period. I must say that from the panelists, I'm looking forward in terms of further engagement beyond this. I know that I did speak to the issue of the index, and perhaps these are some of the things that we need to look at. And the Commission for Gender Equality is a Chapter 9 institution whose mandate is basically to monitor and evaluate the impact as well as the implementation of various programs in the country. We will actually be making sure that during the next financial year and this current financial year, we work closely with institutions in terms of monitoring the impact of programs, of services that have been delivered, in terms of making sure that we address issues of not only mental health, but also with a special focus and a sharp focus on addressing issues of persons with disabilities. I think based on those, Commissioner Mazibuko, I would like to say thank you very much for facilitating so well this particular important session. Thank you very much, and thanks to all participants. Thank you.
Thank you, Chairperson of the Commission, Commissioner Matebula. Can I hand over to the Deputy Chair. Over to you, Deputy Chair.
Thank you so much, Commissioner Masbugo. Good afternoon to everyone who has joined us. I just want to say, just to concur with the Chair, that we are so excited that we have been able to gather almost a consistent number of people in the participation, and we know that there are people who have also watched us live on the other platforms of YouTube and Facebook. I know a lot of us have been asking about whether we can connect again. Is there recording? It is on our Facebook page. You can view anytime the actual recording. Thank you again to our commissioners. Thank you again for every panelist. We are running a webinar series. The next one will happen in 3 weeks on the economy and women empowerment and what are the interventions that we can take forward as CGE and as a country. Please do check out our Facebook and our Twitter pages for updates. We have past series done on GBV and the use of statistics and data. That was done almost 3-4 weeks ago. You can also check that on our Facebook page or on our YouTube. It is available for your use. I want to give a special thank you to all of our guests, as the chairperson has said, but specifically to management for their support. They're always the team behind that we do not see, and to the people who are joining us for the session today. All of you, we just want to say thank you for your support, thank you for your engagement, thank you for your continued inputs into the discourse of the country and where this matter needs to go. And I think, as the chairperson said, let's action things and let's get things going. Thank you to everyone. We will officially close this session and hope that you have a productive and very blessed rest of the week. Thank you very much.
Meeting adjourned.